welcome everybody to the November version of IIDR Rounds. I'm Laurie Burrows. I'm the Associate Director of the IIDR. Before we get started, I was asked by Fiona Smale to provide you with a public service announcement / request. They are still looking for about half a dozen people to complete their safety study for their COVID-19 vaccine. So if you meet the criteria, which are shown in the box in front of you here, that means you've had at least 3 doses of an mRNA vaccine and you've had a COVID infection and you are between 18 and 65. She asks that you please get in touch with them. There's an email address on your screen to enroll in the safety part of this study so they can move on to their next step. Okay, thank you. All right, I'm going to stop sharing and introduce our speakers for today. My other screen has gone to sleep while I was talking. All right. So I'm very happy today to introduce our speakers. So Dr. Marek Smieja is a microbiologist and infectious disease physician based at St. Joe's and a professor in the Department of Pathology and Molecular Medicine at McMaster. He has been involved in the clinical care and research of patients with Clostridioides difficile infection for over 30 years. Dr. Smieja's research interests focus on improving diagnostic tests for respiratory and gastrointestinal diseases. And today he'll be speaking to us about C. diff, infection, and relapse. Our second speaker is Dr. Sheridan Baker, a postdoctoral fellow who is jointly supervised by Dr. Andrew McArthur and Dr. Marek Smieja. He completed his bachelor's and master's of science degree at McMaster before completing his PhD at the University of Guelph in 2021. His research combines bioinformatic and wet lab techniques, such as whole genome sequencing, to better understand infectious diseases, and he is focusing on C. diff, COVID-19, and antimicrobial resistance. Our third speaker is Maddie McCarthy. She's a PhD candidate supervised by Dr. McArthur. She completed her bachelor's degree in microbiology, also from the University of Guelph. Go Guelph! I'm also a Guelph alumna. And her master's degree in microbiology from the University of Saskatchewan, Vito. Maddie's research focuses on developing comprehensive, cost-effective methods for culture-free bacterial genomics. So Dr. Baker and Maddie will be speaking to us today about in-hospital transmission and novel diagnostic and surveillance methods for C. diff. So I will pass the mic over to Marek. Thank you.
Thank you, Laurie. And I just wanted to make sure that you're able to see my screen before I start speaking into the universe.
Looks good.
Perfect. All right. Well, thank you for this opportunity. And I'm really the background and provide a little bit of clinical insight, but the main features will be Sheridan and Maddie. So we're going to talk today about Clostridioides difficile, as you've heard. So my part will be background on C. difficile infection and relapse, and then introduction of the concept of C. diff colonization, and from which Sheridan and Maddie will talk about the in-hospital transmission and novel and diagnostic and surveillance methods. So we'll start with a case. This is kind of stylized, but we'd see people like this, unfortunately, a couple times a week still. 75-year-old female from a senior's home. She's admitted for congestive heart failure. On day 5, she has an episode of confusion during which some blood cultures are drawn, some urine cultures. She has E. coli in her urine and she's treated with ciprofloxacin. And a few days later, she develops diarrhea 5 times daily. She has anorexia, low-grade fever, some fatigue. Her white count goes up a bit, but not dramatically. Her creatinine goes up a little bit, and she has stool sent for C. diff. She's put in isolation precautions. Her C. diff LAMP assay, which is a molecular assay done here at St. Joe's for the city, is positive. And because of her symptoms plus the positive test, she's labeled as hospital-acquired C. diff. She's treated, this was a few years ago, so she's treated with metronidazole, 500 milligrams 3 times daily for 10 days. She improves, but then she relapses 7 days after treatment. On this occasion, she gets what is a more standard therapy today, which is vancomycin, 125 milligrams orally 4 times daily. She gets it for a full 14 days, but unfortunately relapses yet again 10 days after that treatment. She's now treated with vancomycin vancomycin for 14 days, but then she gets what we call a taper, where we give vancomycin 4 times daily for treatment, then twice daily for a week to 2 weeks, once daily, etc. But unfortunately, after a 6-week taper, she goes a couple of weeks and then relapses yet again. And at this point, she's put on long-term vancomycin suppression, which I've talked to some of this group about before, but I will show you a bit of that data. She's referred to fecal transplant, but we've not been able to get fecal transplants because of COVID, because of the need to exclude COVID positivity in the stool itself, and just lack of supply. So we've actually not been able to do any transplants in the last 1 year or so. Dr. Abwa Nasser is in charge of the C. diff service that performs those, and I help out a bit. So what is Clostridium difficile? It's an anaerobic gram-positive spore-forming bacillus. It colonizes young children transiently, but perhaps up to 50% or more of kids are colonized in their first year of life. And then it's not seen all that much, except if you're in and out of hospitals, but certainly in the adult population, a couple percent of those coming into hospitals are colonized. And then in the presence of particularly antibiotics and some other drugs, you get suppression of gut bacteria. The C. diff will sporulate, and it starts producing toxin A and B, which has all of these deleterious effects on the colon. And antibiotics are the main predisposition, but we know it's made worse in the setting of proton pump inhibitors, as well as some chemotherapy. So C. diff diarrhea starts, a diarrhea we define as a minimum usually of 3 loose bowel movements or more per day, but it can literally be 10 to 15 bowel movements. It can be quite explosive. There can be abdominal pain, low-grade fevers. This can go on to pseudomembranous colitis in about a quarter of these patients, and this is a picture of pseudomembranous colitis as seen at sigmoidoscopy or probably at autopsy. You get toxic megacolon in a small proportion of people. That can lead either to colonic rupture or to the immediate need for surgical removal of the colon, and then in a small proportion of people, it does lead to death. These are rates from St. Joe's over the years. This is spanning about the last 15 years. And what you see is, first of all, that there's variability week to week, that you have this huge spike that we had back in 2010, which is when the NAP1 strain really arrived in town, had been active for several years in the Montreal and Quebec City area, arrived in Hamilton and Ontario with a vengeance back around 2010 and caused big, big outbreaks. This particular outbreak had us in outbreak for something like 130 days, and there were over 50 cases of hospital-acquired C. diff, let alone others with community-acquired C. diff. And what you can see is we have control lines of kind of a median and 2 standard deviations, and those control lines have been going lower and lower, and the overall rates here have been going lower and lower. So is this just St. Joe's? Is this something we're doing uniquely here? We certainly have excellent infection control and a lot of attention to proper isolation and treatment. But in fact, this has been a Canada-wide phenomenon, particularly in central Canada. So you have in the blue are data for St. Joe's, and then in those colors, you can see both provincial rates in green, national rates in orange, the lowest line there. And what you can see is all of us had a much higher rate back around 2010 to 2015, and then lower rates since then. And here at St. Joe's, we've also looked at mortality, and there's always mortality in a proportion of people with C. diff because they're very sick patients with a number of comorbidities. So we try to understand and review whether there's, C. diff associated mortality. So Zane Shagla and I, who are the co-medical directors of IPAC here at St. Joe's, we review all deaths. We've done this for a number of years. And since 2009, we've only been able to identify 6 that were either possibly or probably related to C. diff infection. And that's about 1 or 2 per year, which is actually pretty phenomenal because we were looking at probably more like 20 per year back around 2010. So a huge reduction, and a modest reduction, probably about a third to a half reduction in total cases, and a big reduction in complications like colectomy and deaths from C. diff. And then Canada-wide, we can see something similar. This is from Kevin Katz, and again, the Canadian Nosocomial Infection Surveillance Program, or CNISP, which we're a part of, and HHS is also a part of. In this particular article, they reviewed 17,000 cases from Sentinel hospitals all over Canada, mean age of 69, overall about a 4% death among those who have among the deaths, about 4.4 were attributable to C. diff infection. And this is the data over about 7 years. You can see in central Canada, you have the highest rate across Canada, but that peaked around 2010, and it's been going down ever since. Lower rates in the eastern provinces and somewhat higher rates in the western provinces, and again coming down. And again, a lot of this is likely due to the NAP1 strain. And so here they've broken it down. This again is national data. Sheridan will talk a bit about local data for NAP typing and ribotyping, but here for the NAP1s, back in 2009, fully 47% of all the isolates across Canada were the NAP1 strain. By 2015, that's come down to 28.5, and at this point, it's probably less than 13% nationally. And then we've looked at the St. Joe's experience, and this is back a 5-year between about 2013 and 2017. We looked at over 600 cases of first-time C. diff occurring in our hospital by various clinical characteristics, by what treatments they got and what outcomes they had. And some of the things to point out to you is at that time, 80% of people were initially started on metronidazole, but fully a third of them switched to vancomycin. We don't know all the reasons. We tried to understand from chart reviews, but we think most of this is that they were not getting better. And then about 20% started from the beginning on vancomycin. About 16% had relapse. About 17% actually died of something in the first 8 weeks. And these people contributed a median of 16 isolation days. So days when they're in contact isolation while in hospital. And so we looked at a number of risk factors that were predictors of these bad outcomes: age, white blood count, temperature, albumin, and creatinine. And these are very similar to what Ontario Health, or at the time the Ontario Drug Benefit Program, they would pay for vancomycin for our seniors under certain circumstances, and they generally had to have a number of these. And so here we've actually graphed 0 to 5 of these risk factors, and what you can see is that the outcome being either that they switched from metronidazole to vanco, indicating they were not improving or getting worse, or they relapsed, or they died. Even those with no risk factors, about 30% had one of these outcomes, whereas those with, for example, 3 risk factors, over 60%. And based on this and some clinical trial data and other cohort data indicating the metronidazole was inferior, both in terms of initial treatment and relapse compared to vancomycin, we made the recommendation after 2017 that we should always be starting with vancomycin with very few exceptions. And if we summarize what we know about the 3 main drugs we have, metronidazole, vancomycin, and fidaxomicin, metronidazole is reasonably effective, especially for milder, not as effective alone for severe, and we don't recommend it. But a lot of microbiome disruption. It's a very broad spectrum anaerobic drug, and we think that's why it's also associated of these 3 drugs with the most relapse, although it's very low cost. So for people who don't have much money and have mild disease, particularly if they're outpatients, it's still a reasonable option, but certainly for inpatients, we felt that everyone should get at least vancomycin, or some should be considered for fidaxomicin. Vancomycin is quite effective, equally effective to fidaxomicin, but it does disrupt the microbiome more than fidaxomicin and has been associated with double the rate of relapse compared to fidaxomicin. But where metronidazole might be $5 for a course and vancomycin might be $100 for a course, fidaxomicin comes in at about $2,000 for a course. So it's really beyond hospital budgets to use this for every single patient, although we certainly use it in some of our patients where we feel it's indicated. So ongoing since about 2018 here at St. Joe's, and probably very similarly for HHS, we recommend for inpatients that they initially are treated with vancomycin, careful follow-up for relapse. If they do relapse, we'll give them a full 14 days, but we often will give them a taper after first relapse. And again, that's this 6-week course or so of less and less drug after the initial treatment, or we may consider fidaxomicin depending on other risk factors and so on. If they do have a further episode requiring antibiotics in the next 6 to 12 months, we do recommend and routinely use in our hospital vancomycin for prophylaxis. So you come in with pneumonia, you get treatment for pneumonia, but you had C. diff 4 months ago, we'll also give you vancomycin to try to prevent a recurrence of your C. diff. And then we have had patients where they keep relapsing and nothing seems to work, and we put them on vancomycin long-term, 3 months, 6 months, a year, or even longer. We will consider them for FMT, but again, we've not had access to FMT very much in the last 2 years. So that's in prior to that, when we had good access, two or more relapses, or usually over 2 relapses, or 2 or more episodes where any one of them was a severe episode or refractory C. diff were indications for going on to FMT. So in terms of oral vancomycin for prevention, this is still controversial because some of the clinical trials have not been definitive, and Dominic has reviewed those before, but we primarily go by this one article, which is a non-randomized study by Van Heijs, where he compared those in different sort of time durations sorry, that's not true. I think some of the times overlapped between those who did and did not receive vancomycin prophylaxis while they were on an antibiotic for something else. And what they found is only 3 people, or 4%, had a relapse while on vancomycin prophylaxis, compared to 26% in the control group. So a huge reduction of about 88%. And Zane brought this to my attention probably around 2008 or 9, or whenever this was published. And both he and I have been doing this ever since, as does the C. diff service. But we've also used vancomycin long-term, and I'm surprised even when I go to meetings, this isn't in most of the guidelines. But what we found back when we saw a lot of C. diff and a lot of C. diff that needed transplant is some of them weren't candidates for fecal transplant, or some of them failed fecal transplant. So both Christine, Sarah, Sala, and myself got very used to putting people onto long-term vancomycin if all else failed. And this was at a low dose of vancomycin, 125 once daily. And we summarized a case series of about 20 people where we did this. And what we found is that there was only a single occurrence of C. diff while you were on antibiotic, for a crude efficacy of something in the neighborhood of 95%. And these are the actual cases. The bottom one, number 1, is the one that actually relapsed while on treatment, and I believe he went on to fecal transplant. All the other ones did not relapse while on treatment, although where you see an interruption, for example, number 18 towards the top, or number 12, if they stopped, some of them had a relapse, about 40% relapsed, and then if it was restarted, they'd have none. Patient 12 had 2 times they stopped, each time they relapsed, and then finally we're fine after this prolonged therapy. So they had about over a year's worth of vancomycin prophylaxis. But of course, the thing we used a lot that we couldn't use very much during COVID were fecal transplants. And this can be fresh stool or frozen. And then Christine Lee, who pioneered this program here in Hamilton and then moved to Victoria, she developed a method of lyophilizing that was at least 80% effective. And she also worked with a company called Rebiotics that went and developed, I think they were bought out by another company, but went on to develop Rebiota, which is an FDA-approved commercially available FMT in the United States. And Christine went on to show that both fresh and frozen, and then later lyophilized, were very effective in people with relapsing C. diff. And depending on the measure used and whether you're talking the first 1 or 2 transplants or up to 6 transplants, she found efficacy in the sort of 75 to 95% range, depending on how we define this, with very similar in fresh and frozen. And this was a JAMA article she published some time ago. We've also had a few newer drugs since then, and one of them is baslotoxumab. This is a monoclonal antibody. It's a human monoclonal antibody directed against toxin B, and it's been found to be in the neighborhood of 85% effective in preventing relapse, and is certainly used in certain settings, certainly in the States and occasionally in Canada. And then in addition to that, we have what are called live biotherapeutic products. There are two that have been FDA approved. To my knowledge, none of these have been approved by Health Canada. One is called Rebiota. It's a consortium of microorganisms that's rectally administered and is shown to be highly effective for prevention of relapse. A second is encapsulated firmicute spores from donor stool. You first get a magnesium citrate purge, and then you get 4 capsules daily for 3 days. Sounds pretty easy. At least on the website, I found this goes for 17,000 US dollars. So not exactly cost effective from my point of view, but certainly at least available in the States. What I'm more excited about, although I have no idea what cost this will be when it comes to market, but is something called VE303 for Fidanta, which is a bacterial consortium of Clostridia. And we participated in a study that was led by Tom Louie of a randomized trial to prevent C. diff in high-risk patients. And this was from JAMA, about just a phase 2 study, so it still is going on to a bigger study, but 78 people, median age of about 64 years, randomized to either high dose, medium dose, kind of low dose, or placebo for 14 days. And these patients all had previous relapse or were very high risk for relapse. And if you look at the findings on the right-hand side, and at the end there, the placebo, 45% had a relapse. Low dose, it was 37%, and high dose, it was 13%. So what you can see is a grade response between high and low dose, and a very, very high efficacy. In terms of, a dramatic reduction from 46% to about 14% in terms of relapse. This is relapse at 8 weeks, and this is a 14 days of oral capsules that patients took. We enrolled 3 people from Hamilton in this study, and Jody Gilchrist, who's currently works with us in the lab, but is also a PhD student in HRM. She was our lead, research coordinator for this study. So in terms of preventing relapse, we're getting away from metronidazole, at least in the hospital setting. We think it's high risk for relapse, and it's probably an inferior drug for moderate to severe disease. We generally rely on vancomycin. We would use much more fidaxomicin if it were more cost effective, and we certainly do use it on occasion. After recovery, we recommend vancomycin prophylaxis while taking other antibiotics. If you keep having relapses, and we'll go through vancomycin taper, fidaxomicin, but where available, we may start trying to do FMT again in future, but there are options such as vancomycin suppression, which we've really relied on during the pandemic. We've had a lot of people where that's been the only option. And then in future, we have these things that are already available in the United States or becoming available in Canada, like these live biotherapeutic products, those bacterial consortia, and baslitoximab. But certainly at this point, even if they were available, if they're at the sort of costs that we see in the United States, hospitals may have a very hard time finding it in their budget. So this is what happens when we get clinical infection. But an important lead into the next 2 talks is, can we detect colonization? So when people have asymptomatic infection, and can we predict C. diff infection, both in individuals and being transmitted in hospitals in the first place? So the background to this is a study by Yves Longtown from Quebec City, who looked at detecting and isolating C. diff carriers on hospital admission. So he would do PCR on everybody coming into his hospital in Quebec. They would then give them some low-level isolation if they had C. diff colonization, and he estimates about a 62% reduction in hospital-acquired C. diff as a result of doing this. Now, this was not a randomized trial. This is simply a before-after, although he did try to compare it with rates in other Quebec hospitals as well. And what you can see here is over many years, rates are around 10 per 10,000 with a lot of spikes above it. And then starting in their intervention around 2013, 2014, a dramatic lowering and a persistent lowering of their C. diff rates. Now, I've heard they've stopped doing this during the pandemic. I have not seen follow-up data. Don't know if Dominic knows of longer-term data, but the jury is still out whether this is a good universal application of, whether this is something we should be routinely screening for. But Dominic has led a large local study to try to understand C. diff colonization and try to develop studies to take it further. In an initial cross-sectional study, we looked at a large number of patients and 10 high-risk wards across hospitals here in Hamilton. And what Dominic was able to show is about a 6.6% colonization rate. It varied by hospital from 3.5 to almost 8%. But those who had C. diff and stayed in hospital, C. diff colonization and stayed in hospital, about 10% of them went on to develop C. diff at a follow-up during that hospitalization. So we believe C. diff colonization plus starting an antibiotic does lead to more C. diff infection. And we have a pilot study, which so far is still struggling to figure out how to become a feasible study, but the plan was to randomize to vancomycin probiotic or placebo to see if we can prevent hopefully a large proportion of clinical infection. But the other thing that was very important in Dominic's study is that C. diff colonization, if you repeat the testing at intervals while you're in hospital, it goes up during hospitalization. It goes up from 4% to about 6.6%. And while some of this may be selection of sicker patients, it does seem to indicate that there is some level of transmission of asymptomatic C. diff within hospitals, and that hospitals are a risk factor for getting colonized. And if that's true, then just like in the Quebec study, we may have to put more effort into detecting it and trying to prevent its transmission. So with that background, I'll turn it over to Sheridan.
Hi, so I'll be talking a little bit about some of the transmission data we've been looking at in the decency study. So first, a little bit of background on toxins in C. difficile. The main virulence factors are two exotoxins that are secreted by the bacteria, known as toxin A and toxin B, and they disrupt the actin cytoskeleton and epithelium in the intestines, leading to cell apoptosis and cell death. Now, some strains produce a third binary toxin made up of two subunits, the CDTA and CDDP B subunits, and they're found in about 20% of C. difficile strains and are associated with more severe disease. The current testing recommendations for C. difficile in Canada only recommend the testing of patients with symptomatic diarrhea, and they specifically say that asymptomatic patients should not be tested for C. difficile, and that routine environmental testing should not be done. They sort of think it's not worth it. However, it's been proposed in recent years that the testing of patients for asymptomatic carriage may reduce incidence rates of CDI, like we saw in that Quebec study by Yves Fontaine. So the aims of this part of the decency study were to determine whether asymptomatic patients harboring C. difficile contribute significantly to in-hospital transmission of C. difficile infection, and to investigate the toxin gene prevalence compared to a previous severe outbreak. How we went about doing this is there were routinely collected rectal swabs for VRE or MRSA, and they were additionally tested by PCR or LAMP for the presence of C. difficile. Positives were then cultured, and from those cultures, we were able to sequence a high proportion of them using whole genome sequencing. After whole genome sequencing, I constructed some trees to look at the relatedness of the samples, as well as using some bioinformatic tools to assess the presence or absence of toxin genes within the samples. Unfortunately, we're missing some demographic data from all the patients that were screened. However, the patients that were swabbed and then subsequently cultured were just over 50% male with an average age of just under 70, with the females just over 70 in average age. The sequence patients didn't differ significantly from that. 54% were male with an average age of 72, and 46% were female with an average age of 73. And there were no significant age differences between any of these groups or between the sexes. So 1,469 patients were screened in the study for carriage of C. difficile. And of those patients that were screened, 50 or 3.4% had C. difficile infection at some point during their hospital stay. However, there were more patients than that tested positive for C. difficile. So 6% were LAMP positive and PCR was not performed, and a further 5.3% were both LAMP and PCR positive. 154 of those 167 were sent for culture, and 54% of those that were cultured were positive for C. difficile and were successfully cultured. We tried to sequence all 74 of those culture positives, and 44 of the 74 were able to be successfully sequenced, representing 29% of the group that was sent for culture. I then made a phylogenetic tree and combined the phylogenetics with some epidemiological data to try to determine where potential transmission events may have happened. And the criteria for assigning a potential transmission event to the tree was that patient samples were from the same clade on the phylogenetic tree. Patients had to be hospitalized in the same hospital ward within 3 weeks of each other, and patients had swabs taken at least 72 hours post-admission. And that's to try to capture the in-hospital transmission events rather than community-acquired C. difficile. We did expand the search at one point to physically adjacent wards, but this revealed no new potential transmission events. So we went with the stricter criteria of that they had to be from the same hospital ward. So this figure is the tree I was able to generate. The MLST multi-locus sequence typing is shown on the right beside the bracket, of which there were 17 types found throughout the tree, and they're primarily monophyletic with high bootstrap values. I should note that some of the samples don't have MLST types shown beside them, and that's if one sample was the only representative of that MLST type. And then highlighted in the various colors are the potential transmission groups we've been able to identify. So we found 9 throughout the tree, each consisting of 2 or 3 patients each. And of these 44 successfully sequenced samples, 54% were members of an identified potential transmission event. And basically all the ones that group together and look clonal appear to be a part of a transmission event. There's some like in MLST type 10, where there's no evidence of in-hospital physical overlap. So it's likely one did not acquire from the other in the hospital. So it's possible that they are from the same long-term care home, or some other community acquired event happened to transmit between those. And so I'll just zoom in as an example on one of these clades. So there's 2 potential transmission groups within this clade. Pink, they were from the same ward, same hospital with a 3-day overlap in hospitalization. And blue were all from the same ward, the same hospital with a 15-day overlap in hospitalization. And while sample 40 appears to be genetically related to the pink group, it was ruled out from the transmission group due to physical distance from the other samples within the hospital and a lack of temporal overlap. We also looked at toxin gene prevalence within these samples. So there was an outbreak of C. difficile that was primarily NAP1 in 2014-2015 in Hamilton and Peterborough, and we have sequences for that. So what I did was I used a program called Abricate to search for these 4 genes sequences within the whole genome sequences, and I was able to plot on this graph the percentage of genomes that contain each specific gene. So in all cases, TCDA, TCDB, and then the binary toxin CDTA and CDTB, the gray bars, which represent the previous outbreak, showed significantly higher incidence rates of these toxin genes compared to the current samples. And that kind of makes sense since the previous outbreak had a very, very high proportion of NAP1 samples, which are associated with worse health outcomes and higher incidence rates of the toxin genes. So this is good. We've been able to drive down the toxigenic C. difficile strains present within the Hamilton community. So what we've concluded from this study is that asymptomatic carriage is much more prevalent in the community than previously thought, and asymptomatic transmission is a significant source of in-hospital transmission events. We're suggesting that repeated swabbing of hospitalized patients is required to further investigate the in-hospital spread of CDI, as we just were able to capture a snapshot at one point in time of whether or not these patients had C. difficile at that point in time. So by repeated swabbing, we'll be able to see when they get them and perhaps be able to determine directionality of transmission, which we weren't able to do in the current study. Circulating C. difficile strains in the community are presently genetically diverse, as we saw 17 MLST types across the 44 samples. And higher incidence rates of C. difficile toxin genes are associated with worse health outcomes. PCR screens for these genes may be valuable for assessing likelihood of CDI outbreaks, which leads to my future directions, where I'm currently designing some PCR screens for typing of C. difficile. So the current method of culturing and then going to whole genome sequencing is time consuming. And a potential solution for that may be a multiplex PCR screen. So if we're able to identify the MLST type quickly of samples with rapid turnaround, there are sort of two outcomes to that. If we see this same MLST type in multiple samples, that's potential transmission between the two, and we could proceed to whole genome sequencing to determine if the samples are in fact genetically related. Whereas if there's different MLST types between samples, they're likely unrelated, and there's no need to declare an outbreak in that case of in-hospital C. difficile outbreak. And with that, I'd just like to acknowledge everyone that's helped with the project, the McArthur Lab, Sheridan Lab, Jayleigh, David, and Zachary, and the funding partners. And with that, I'll turn it over to Maddie.
Thanks so much, Sheridan. So my portion of the talk is really focusing on culture-free genomics for outbreak detection and surveillance of C. diff. Whole genome sequencing is really the gold standard for outbreak detection and surveillance. But as Sheridan just mentioned, C. diff culture is kind of slow. Rather than hours, it takes like 2 to 3 days. It requires specialized equipment to maintain that anaerobic environment. And we really can't reliably guarantee that we're going to be able to identify multi-strain infections if we're just picking culture. So one alternative to whole genome sequencing that's relatively well known is shotgun metagenomics. So with this method, all of the DNA in your patient sample, whether that might be stool or blood or a swab, that's directly extracted, and then you sequence that DNA. So there's no culture involved, which means that we're able to sequence C. diff, or our species of interest, without having to culture it. But that also means that we're sequencing everything else in the sample as well. So especially in a stool sample, you'll be sequencing the normal microbiome that's supposed to be there. In other sample types, you may be also sequencing mostly host DNA. And even if we do a host DNA depletion, there's still other bacteria or viruses or fungal sequences in that sample. So you're spending a lot of time and money sequencing things that data you're going to throw out because you're not interested in it. And it requires a bit more bioinformatics effort post-sequencing to work through all of that data. So an alternative to shotgun sequencing is target enrichment or bait capture. So with this method, same as shotgun sequencing, we're extracting DNA directly from a patient sample. And then we use custom designed oligonucleotide probes to bind to that C. diff DNA. All of these probes are biotinylated. So using magnetic beads, we can pull out the C. diff DNA, physically separate it from all the DNA we're not interested in, and end up with a sequencing library that primarily contains C. diff DNA. So bait capture significantly enriches for those target DNA sequences and helps to reduce the time and costs associated with sequencing those other off-target DNA molecules. Bait capture directly from patient samples works quite well, even for whole genome capture. Over the past 8 or so years, there's been multiple proof of concept studies for different bacterial species, especially things that are considered rather difficult or slow to grow, like Mycobacterium tuberculosis or certain STIs. But despite the success of those experiments, bait capture really hasn't escaped from academia and broken into regular use in the clinic. So the main focus of my research is figuring out how to overcome some of those primary barriers to clinical adoption. And the first one of those is really a lack of user-friendly, flexible bait design software specifically built for outbreak investigation. Existing bait design software is either too narrow, so for example, programs that only design baits for something like Mycobacterium tuberculosis, or it might be too broad, so it designs baits for hundreds of bacterial species all at once in a single bait set, or it requires a bit of legwork, so the user might have to curate their own set of reference genomes or provide a phylogenetic tree. The second barrier is just the cost of baits themselves, so there is historically a high upfront cost to bait capture. Depending on the size of your bait set, it may cost hundreds of dollars per reaction. So to address the software issue, we've created this software called BacOps, which stands for Bacterial Oligopools, for culture-free outbreak detection and surveillance. So the theme of this talk is C. diff, but keep in mind that this software can be used to design bait sets that capture the whole genome of any bacterial species you're interested in. There are customizations at almost every step so that the final bait set is suitable for whatever purpose you have. We have a bunch of different options to include or exclude baits for integrated viruses, AMR and virulence prevalence information in your target species. And each of these bait sets is compatible with both long and short read library prep just for maximum flexibility. Just a very, very quick overview of the general workflow. The only thing required to run the software is the name and the NCBI taxonomy ID of the bacterial species you're designing baits for. The software downloads all publicly available genomes for your target species. And we do that because if we include all available genomes, we're making sure that we don't leave out any known strains, because if we don't create baits for all of these, we may miss some genes and not end up with a complete genome. Because this is public data and the quality often varies, there are multiple filtering steps to ensure that baits are created just from those high quality genomes. And we screen each of those genome assemblies to remove both contaminated contigs and any small pieces of contaminating DNA that may have been mistakenly incorporated into the genome during assembly. Those are all removed just to make sure that we don't create baits that capture DNA that doesn't belong to our target species. And then finally, we take that clean set of high quality genomes and create a large set of 80 nucleotide baits. So for each genome, you chop it into 80 nucleotide pieces. Those are filtered to our desired coverage level. And then we also remove baits that happen to bind by chance to off-target DNA, so host DNA or other bacterial species. The rule of thumb for bait capture probes is that they can bind to a nucleotide sequence that differs by up to about 15%. So there's customization built in to adjust these filtered probes if the coverage of your species is too low after removing those cross-hybridizing baits. I just want to highlight one of these cost-reducing customization features. So we used BacOps to create a C. difficile bait set using over 17,000 C. diff genomes. That was filtered down to 258 high-quality, non-redundant genome assemblies. And when those were chopped up into 80 nucleotide pieces, we had over 20 million baits. So in addition to the regular filters that we use to reduce redundancy and remove cross-hybridizing baits, you have the option to decide between an overlapping and a gapped bait design. So in the overlapping design, all of these baits are tiled across the genome so that every 20 nucleotides, there's another bait. Each bait overlaps with another by 60 nucleotides. And that ensures that there are lots of baits covering each position of the genome, and is a popular option for bait design, especially for things like viral sequences or ancient DNA. So with this method, we created a C. diff bait set of approximately 215,000 baits covering the C. diff genome. And that gave us an average of about 90% coverage just with our computer in silico estimates. Our other option is to use a gapped bait strategy. So in this case, we would put a 100 nucleotide gap in between these baits, and including that gap reduced the size of that bait set quite a lot. So we're down to only 116,000 baits covering the genome. But the coverage estimate is still quite high at about 85%. Keep in mind that these baits are only 80 nucleotides long, which is shorter than the DNA fragments in our library prep and the sequencing reads themselves. So when we actually use these experimentally, we expect that we'll capture even more of the genome than this computer estimate is showing. I just wanted to highlight some work done by Dirk Hackenberger, who's a PhD student in the Poinar and Wright labs. So Dirk has actually developed an in-house bait synthesis method here at Mac. So previously, a bait set this size would have cost you hundreds of dollars per enrichment, but now we can use backups to create this file containing all of our oligo pool sequences. We send those out to be made, and then Dirk can synthesize the baits right here, reducing our cost per enrichment down to less than $1. And you can see even already that gapped bait set reduces our total price per enrichment by 50%. If you're doing this in your own lab, you'd need to still purchase beads and buffers. So you're looking at probably still under $30 per enrichment compared to hundreds, making this a fairly appealing strategy. So we're currently validating our gapped C. diff bait set. Hopefully we'll have that data soon. We have access to C. diff swabs that were previously cultured and sequenced. So we have those high quality genomes. So for this validation pilot project, we're using the same swabs to test out our gapped bait set, and we're comparing our bait set genomes to shotgun metagenomic sequencing. So our goal is to recover all of the genome, and if we can't quite get the complete genome, enough of it to perform core or whole genome multi-locus sequence typing, which would allow us to identify outbreaks. So we're looking at three main things. The first is our capture efficiency. So how much of the genome are we able to recover using our bait set compared to standard shotgun metagenomics? Because we have those complete genomes already, we'll look to see if our bait sets are complete, so whether or not we're missing genes or regions compared to those culture-based genomes, and ultimately identify whether we can use these bait sets for outbreak detection. If that data looks good, we're planning to test this bait set on an actual C. diff outbreak. I have a little bit of time left. So the work I've touched on so far really centers around short read sequencing because Illumina sequencing is already readily available and widely used in clinical settings. During the pandemic, a lot of hospitals began using nanopore sequencing for faster COVID sequencing. So because that is available and long reads open up a lot of possibilities to optimize bait capture even more, we're planning to continue optimizing our current bait tiling strategies and take advantage of those long read sequencers. So if we have longer reads, in theory, we can design smaller bait sets because it takes fewer baits to capture that target genome if it's in larger pieces. We can also take advantage of things like methylation calling to try and identify plasmids in our target species. And ideally, we want to get to the point where we could design a cost-effective bait set to capture 3 or 5 or 10 bacterial species. And in addition to optimizing those bait sets, we're trying to speed up the total time to outbreak detection. So we're looking at software-based enrichment to try and eliminate the need for physical baits altogether. And I'll see if I can speed through these slides in my last couple of minutes. So for software-based enrichment, we're planning to use a method from Oxford Nanopore called adaptive sampling. Just a very quick background on nanopore. Each nanopore flow cell has these protein pores that are embedded in the membrane, and an electrochemical current flows across that membrane. So as each DNA fragment gets fed through this pore, as each base goes through this electrochemical current, it disrupts it in a very distinct manner. So those disruptions can be converted back to base calls to get the actual sequence of that DNA fragment. Adaptive sampling uses software that determines in real time whether or not to sequence each DNA fragment. So you provide a reference sequence or a set of reference sequence, in this case, 1 or more C. diff genomes, to that sampling software. And as each fragment goes into that pore, the software will try to map the first 200 to 500 bases back to one of your reference sequences. If it finds a match, the pore will keep sequencing. But if it doesn't find a match in that first 500 or so bases, then the electrochemical current across the pore gets reversed. The DNA molecule is actually ejected from the pore, freeing it up to start sequencing a different DNA fragment. So similar to bait capture, the end goal is to sequence only DNA from your target organism, but we don't have to do the entire enrichment step and take extra time before sequencing if we can get adaptive sampling to work. So this could be a viable method for quickly sequencing C. diff outbreaks if we're able to capture enough C. diff DNA from those patient swabs. So I just want to say a quick thank you to everyone in our lab for our help and support. Thank you to all my committee members, and a special thanks to Jaylees and Dirk for all their help. So with that, thank you so much for listening this morning, and I'll turn it back over to Lori for questions.
Thank you so much for those great talks. So we have a lot of questions. Marek has answered a few by texting back, so thank you, Marek. But I'll start at the top of the unanswered list. So the first question is, are there any studies done on potential risk factors that may drive colonization to infection so patients can be selected for prophylaxis?
Yeah, so certainly in decency, the main one we think is just concomitant to other antibiotics. So if you're colonized plus you get antibiotics, you're at higher risk of infection. So that's the primary one we've been using for hospitalized patients.
Okay, so the next question is it possible to do toxin testing to help detect colonization versus active infection for patients?
So the issue there is that PCR and LAMP will over-detect C. diff. It doesn't distinguish colonization from infection. We don't currently do toxin because the toxin assays are less sensitive. They undercall, and we'd rather overcall than undercall. But we use kind of clinical judgment. Our infection prevention and control service tries to properly classify people as you know, are they truly C. diff? If a person's had surgery, constipated, they get a laxative, they get a bit of diarrhea from the laxative, and they are C. diff positive, we almost always just let them settle down without treatment. They settle down, we say it's just C. diff colonization. But attempts to use toxin for that purpose are kind of not necessarily, they really, I don't think they entirely solve the problem. So you definitely have symptomatic people who are toxin negative because the toxin assays are just not as good as PCR. So it's still clinical judgment for those borderline cases.
Yeah, and I think Sheridan's data show that the current strains are not as toxigenic as some of the past strains.
Yep, yep.
Okay, so the next question is there any data for C. diff colonization in the high risk for complications population, such as the transplant ward at the Juravinski?
Yeah, so we included 10 wards, you know, pediatrics, and at least 2 wards at each of the general, the Juravinski and at St. Joe's, and we found, you know, 0% up to 21% in various wards. I don't know if Dominic wants to speak to it, but we would certainly consider, you know, an oncology ward to be higher risk for colonization because of the number of antibiotics they usually receive, and they're in and out of hospital. We think this is a bit like MRSA and VRE. The main risk factor for C. diff colonization is probably having been in hospitals, or at least that's a major factor. And then the main risk for then getting clinical disease is to additionally get antibiotics.
Okay, thanks for that. The next question is for Maddie. Does your BacOps software work for non-bacterial pathogens such as protozoa or viruses?
So at the moment, we're just focused on bacteria. There's another student in our lab, Jaleese, who is working on bait capture for viruses. So he's written both Signal for COVID work, and he has a program called Viral Step for viruses. But yeah, it would take some reworking to work on, look at non-bacterial pathogens at the moment.
Okay, thanks. Next question is also, I guess, for Maddie, because it's about bait capture. So for C. diff bait capture, have you tried to reduce the number of baits by targeting highly conserved regions only?
Right, we haven't done that yet, mostly because we're trying to get as much of the genome as possible. Depending on what you're interested in, yes, that might be a strategy if you only need a certain number of a certain number of genes or regions to get your answer. For now, we've sort of gone big and tried to get as much as we can cheaply, but as we continue to cost reduce, we may look into things like that.
Okay. Dr. Wright wants to know if he's very intrigued by adaptive sequencing and wants to know if the pores can be made in-house, or is this a service by Nanopore? He wants to undercut Nanopore, apparently.
Yeah, at the moment, it's all, the flow cells are all Nanopore specific, so I don't think that there's any in-house capability to change the pores, but I don't know, maybe in the future.
Well, at least you're saving the ones that you do have by kicking out the sequences you don't want.
Exactly.
Okay, next question. What is the maximum duration from last CDI, so C. diff infection, to not consider prophylaxis when using antibodies for other clinical syndromes?
Yeah, I don't think we have agreement. I think Salah uses 6 months, so at least within 6 months of previous clinical to give prophylaxis. When Zane and I first introduced this, we talked about doing it for up to 2 years because that was that Van Heist paper that I mentioned. So I think, my consensus is at least in the last 6 to 12 months, if you've had an episode, consider prophylaxis. And ideally, we'd actually, at the 12-month mark, if people needed any, ideally we'd test them for colonization because they're probably either still colonized and at risk or not colonized, but we don't offer that test clinically right now.
Okay, thanks for that. Dominic says he can't speak to the cancer ward because of the setup of Zoom, but he said colonization rates are similar in the hem-onc population as in the general medicine population. I had a quick question for you about this JAMA study. So with the strains of Clostridia that are being used to, I guess, replace C. diff, is that going to complicate the sequencing that Sheridan and Maddie are trying to do, because you're now having additional Clostridia there?
Yeah, they're Clostridia, but they're not Clostridium difficile, I don't believe. And if there are, some people have used non-toxigenic strains. I think, no, I mean, Sheridan and Maddie can presumably first focus on, is there toxin genes present? And if not, it's, so just like Mike Surratt does a lot of work on looking for, some of our probiotic strains of lactobacillus for clinical trials and so on. In the same way, if we start using these, then obviously we'll have to have some way of differentiating them, but they're it shouldn't be hard. So, but Sheridan, did you want to comment on that?
Yeah, because we're capturing the whole genome, there'll be differences between the various Clostridia species that are being used as probiotics versus C. difficile. So we can sort of ignore the sequences that are not C. difficile.
Okay, and are you guys doing environmental surveillance for the strains that you're following, or is this just straight from patients?
This has all been from patients, although we are looking at a method for patients, but it's called banana broth, where you actually swab the environment and then see if it grows. But we haven't done that to date. We're pretty sure you'll find it in rooms with people that are colonized, and certainly infection control has very rigorous ways of cleaning these rooms and cleaning them after patients discharge to try to prevent spores, being in the bedding. There's one wonderful article from, I think, New York, where they looked at 100,000 people who were admitted to a bed where the previous person in that bed had antibiotics, and just being in the same bed as somebody with previous antibiotics doubled your risk of C. diff. So, again, asymptomatic transmission is probably happening more than we think, but where we know they have C. diff, we're very, very good at cleaning and so on.
Yeah, so how have the infection and prevention control practices changed from the 2014-15 outbreak till now to address this?
Yeah, the 2010 was the big one for us. The 2015 was a smaller one. So 2010, we had a huge outbreak that was in the press. There were media teleconferences, all sorts of things. And at the time, we didn't actually have a formal medical director. So Christine Lee was appointed after that. We had an external review of all the things we do, how we could have done them better. We actually introduced PCR during that outbreak. We were using an old toxin A and B EIA. And by introducing a PCR, we could capture those borderline cases that we were missing. And then we introduced FMT. We tried to isolate people quicker. But in 2010, we actually went to the draconian step that every antibiotic prescription in our entire hospital had to be approved by ID. We really tried to minimize unnecessary antibiotic use and unnecessary PPI use. So huge amount of work, bad outbreak, but we've, knock on wood, not seen bad outbreaks ever since. But that was the NAP1 strain, and it did similar things for years in Montreal and Quebec.
Okay, I don't see, oh, wait a second. Is there another question coming in here? Nope, I think we're done. Great. Thank you so much, everyone, for your great talks and for the lively discussion afterwards. And have a great day. I'll see you in December.